Good afternoon, my name is Majed. I'm a U2 medical student attending here at the University of Sharjah, and today I'll be discussing hypertrophic pyloric stenosis. So what is it? So it's basically thickening along hyperplasia of the pyloric sphincter. This causes gastric outlet obstruction, which means none of the gastric contents in food can pass through the after the stomach into the other parts of the gastrointestinal tract. So it's the most common cause of obstruction in these infants. So the presenting signs and symptoms are usually in the first months of life. They present between 2 to 7 weeks of age, and it's usually in a male. They're 4 to 5 times more prone to hypertrophic pyloric stenosis. One of the most important signs that we can see, which is projectile non-bilious vomiting. As you can see, the vomit here is projectile, which means it goes for a good amount of distance, about 3 feet. It's non-bilious, which means that it has not passed the stomach and it does not went into the intestine where bile is present. So it's usually not the color of bile, which is bright green. It's more on the pale whitish side or cloudy, vomit. It's not like normal bilious vomiting. It's non-bilious. And these infants are hungry vomiters. By hungry, I mean, although they have, the need, requirement of having food or nutritional, needs, they are not fulfilled. So these infants are hungry. They always want to, feed on milk, and it's usually bottled milk. But unfortunately, they vomit whatever they take in. So it's after feeding, keep vomiting. The second important symptom, which is enlarged olive-shaped non-tender pylorus, which can be palpated in the right upper quadrant right here, and it's usually on the right side of the umbilicus. The third important symptom, which is poor weight gain and dehydration. So if none of the food contents can be digested or absorbed, as we can say, and most of the things and contents are vomited outside the body, the baby would not gain any weight, and you can see a baby with cachexia. And another important sign is dehydration. These patients lose a lot of fluids and electrolytes through vomiting. And we can see visible peristalsis from the left to right in the epigastrium. Well, usually the pyloric sphincter is closed, and this is to allow food contents, which is milk in this case, in that infant, to be digested and churned and, broken down into, semi-solid, in the semi-solid state, and become chyme and flow into the intestines and whatnot. But the flow into the intestines is facilitated through peristalsis of the stomach, a strong peristalsis, which allows food contents to move through. But in this case of hypertrophic pyloric stenosis, this would not happen. So although the stomach is trying to compensate and increase peristalsis, or we can see increased peristalsis that is visible to us, none of the food contents can pass through. And now we're going to move on to the risk factors and causes. Although the, pathology or pathophysiology of the disease is not really well understood, but there is many risk factors and causes that have been attributed to it. So bottle feeding is a very important risk factor. So bottle-fed babies. This is, usually due to two factors actually that fall under bottle feeding. So bottle-fed infants usually drink a larger amount of milk in a shorter time period compared to the normal conventional breastfeeding. And the other, this also leads to overstimulation, and pyloric sphincter hypertrophy. The other mechanism is these formula milk or these contents that are not natural or the synthesized. They contain some contents which are not readily digested, so this can decrease gastric emptying and also cause pyloric sphincter hypertrophy. The second factor, which is these babies with macrolide, we supplement macrolides within 2 weeks after birth. They can also have an increased risk of manifesting with pyloric stenosis, macrolides such as clindamycin, for instance. And the third important factor, which is firstborn children, which are usually male. So it's usually in a firstborn child that is a male. So males are 5 times higher, as I've mentioned previously. Nicotine exposure during pregnancy is also a vital risk factor, which can cause the hypertrophic pyloric stenosis, and relatives and genetic history with the same presentation, they can also have an increased risk. And you can see the baby with poor weight gain, weight loss, and cachexia, it's failure to thrive, basically, which is also a characteristic of pyloric stenosis. Coming to the diagnosis and treatment now. So these patients vomit gastric contents, such as, hydrochloric acid. This means that they're going to be left at hypocalemic, hypochloremic metabolic alkalosis. This is actually due to the vomiting I've mentioned. They keep vomiting; it's persistent, and then we want to treat this these manifestations and side effects that have happened, of the disease. We have dehydration to be treated first, so we treat dehydration. We replace the fluids, electrolytes, of the infant. And the second important factor, which is pyloromyotomy. So it's a longitudinal incision. It's an incision in smooth muscles, and it can relax that sphincter and allow the emptying of these food contents to pass into the intestines and whatnot. And a very important diagnostic feature is using the ultrasound. We can see a target sign right here, which is characteristic of hypertrophic pyloric stenosis, and also it is present in diseases such as intussusception. So that's why the clinical history matters, of the patient. The second, important factor, which shows the thickened pyloric sphincter along the lengthened, pyloric sphincter right here. So it's lengthened, it's thickened. Moving on, we can put all these pieces of information into one picture. So we can see the age, which we've mentioned. He's brought to a physician by his mother after recurrent non-bilious vomiting. So we've emphasized non-bilious vomiting. And then we can see that he has an epigastric mass, which is the olive-shaped mass I've mentioned. So what would this patient show? So it's a patient with hypertrophic pyloric stenosis with elongated and thickened pylorus on the abdominal ultrasound. I hope everything was clear, and if you have any questions, you can leave them in the comments below. Thank you.